Next presentation will be by Dr. Vishal Rao. He is Group Director of Head and Neck Surgical Oncology and Robotic Surgery at HCG Cancer Center, Bangalore.
A very good morning to all of you. At the outset, I would like to thank the organizers of OM, Kaustubh sir, Toprani sir and the entire team. So I've been asked to speak on TNM staging, disease mapping and pre-treatment evaluation. So without much delay, I've divided the three parts of it into these three areas. We have Dr. Dikruz, who's been a part of the TNM staging, part of the UICC. I think he has contributed very significantly for the 8th edition. So I've taken bits and pieces from this. But I think for the youngsters, the postgraduates, fellows, I think earlier I thought the learning days when we used to do a VDL, we gave a lot of importance to the aspects of anatomical sites, subsites, the ICDO, which today has become less and less significant for a surgeon. Somehow we are getting busy with the moment there is a lesion, you send it for CT, RT or RT without actually mapping the site, subsite. And I thought this is one simple area which we can make a difference in our documentation day to day. If you study the ICDO correctly and if you monitor and see and write these terms correctly, this actually has a significant bearing on the cancer registry. This has a significant bearing on our documentation. So I think a cancer staging always begins with a good ICDO terminology and using the right name. Just writing a CA larynx or just writing CA pyriform fossa may not do. This is one point that I wanted to mention here. The current 8th edition very nicely elucidates the ICDO, which ICDOs are there. And remember, the ICDO sites versus the sites and subsites in the TNM are different. However, it is important to note this because your medical record department will actually be following the ICDO. So please do try and follow this, because this will actually make a difference in our registries, in the way we analyze it, and then finally we ourselves are going to use this data from ICMR or the National Cancer Grade or from registries and then present it with wrong data. So this is a simple point that I wanted to mention here, that very clearly defined points are there, and again specifically for pyriform fossa also, because this is an important area, especially when it comes to post-cricoid, when we often get confused, because today the staging system at post-cricoids is, when it involves the esophagus or does not involve the esophagus, has an important bearing on decision making for treatment. I've tried to keep this as simple as possible. I know this is our interior of the larynx, this is something that we are going to talk about, and this is the hypopharyngeal area, so I'm going to keep my focus on these two areas in these topics. Again, just for the sake of reiteration, I know we all know the TNM staging. We have the supraglottis with most of it again focused on, limited to one subsite, more than one subsite, then vocal cord fixation and extrathyroidal extension broadly. And this is how the flow of the entire philosophy of TNM goes. Now, I think all of us have been busy with this area, because I think finally it boils down to duoscopy. If vocal cord is fixed, send it for CT/RT. If vocal cord is not fixed, we can still amenable for organ preservation, the surgical way or the non-surgical way. Now, I'm not going to spend more time on just telling you what this is, because most of them would be aware or have access to it. But I think in the larynx, which is the supraglottis, the glottis and the subglottis, much largely the philosophy remains around those important spaces of the epiglottic space, the paraglottic space and the thyroid cartilage. These three terminologies, and when it comes to subglottis, the cricoid cartilage. In sum total, it is these four elements that we debate around, look at where they are around the tumor and how do they impact the functionality of the tumor. So even with lymph node, I think the most important thing that has happened of late is the the addition of 3B, which is clinically can be assessed by either pinching the skin involvement, the dermal involvement, fixity, or looking at nerve involvement. I think there are 3 points simply clinically that you can come to a conclusion to say there is extrathyroidal, there is extra nodal extension. Now these three simple clinical tools can actually bear a significant bearing on your clinical staging. Again, something which is very often missed in our documentation when we start the first, I would say, examination of a patient. Sometimes in a busy clinic, it could be a junior fellow, or it could be a resident who's mapping this. But I think this system again will have a profound bearing on your registry, on the documentation. Similarly for hypopharynx, again, nothing major has changed overall, but look at T4, and the aspect I wanted to highlight was involving the esophagus. So a lot of the times in hypopharynx, esophageal involvement is considered T4, and beyond that, I wanted to go into the oropharynx. Now in India, oropharynx setting, and I've specifically picked up P16 positive. And look at the larynx has also got a mention that it is T4. Although it will be stage 3, it is still T4 in P16 positive. It is important to note because a lot of the time we get base tongue lesions which may be P16 positive, eventually more and more of them to see, which will be stage 3, and the mucosal extension to lingual surface of the epiglottis from primary tumors does not constitute invasion of the larynx. And I think this is an important point to find, but for us, because oropharynx, because of chewing tobacco, is a common finding that we encounter. Dr. De Cruz mentions his finds here, sir, so I'm acknowledging you, thank you for that. But this is a very nice prognostic factors grid, which the TNM gave for laryngeal and hypopharyngeal cancers. A very relevant one. They said essential ones are tumor related, host related, and environment related. And today, much to the concept of One Health, post-COVID that we are talking about of the host, the human and the animal environment, we are today talking even in the tumor the same way, that there is going to be a tumor microenvironment, there is going to be a cancer cell, the genomics, and they have elucidated this very nicely. And I think a lot of emphasis and work can be achieved by just simply focusing on these areas, the TNM, the extracapsular extension, comorbidities, the age, performance status, and ability to perform a standard treatment. And just on a thought-provoking note, I wanted to maybe put this as an appeal to the home team and FHN also. We follow the American College of Surgeons risk stratification category. I use this often to give it as a risk category to tell the patient what risk he belongs in, which is more of a counseling tool, because everyone today wants to know what's the risk category. Because I hear people say he has got a 50% chance of mortality post this surgery to 25%, and sometimes you hear it very arbitrary. So just to kind of objectivize it, there are various scales like this. There is a head and neck specific scale also for risk assessment, but I found the American College of Surgeons scale very simplified, easy for the patient to understand on what is the risk he has if he has to undergo this surgery. So a patient who came to me saying, I have a 50% chance, when we analyzed him, had a 2% chance of mortality. This makes a lot of difference, and this is officially documented. We could build this based on these kind of things, and FHNO and our research teams can take this up. Now additionally, we have a lot of interesting other areas which they have mentioned, like tracheostomy, vocal cord impairment, tumor volumes, no lymph nodes, region involvements, gender, laryngeal function, and which is what I'm going to talk about, nutrition, social environment, and overall treatment time. I think these are all relevant factors which we should try and capture. I feel India, one of the largest neglected topic is nutrition, because we are so busy treating the tumor that nutrition is often neglected in head and neck. So an integrated approach of speech and swallow assessment and diet team working together can be a game changer in head and neck for our patients. And they've definitely talked about a lot of new areas which we should start focusing on now. And I think these are looking at tumor markers to slowly enter. So I think they are somewhere entered into our system. Now, coming to the second aspect of what I was asked to speak on, disease mapping, and which is integral to staging. Now, this aspect of disease mapping again brings together how do I map this, and I'm again reiterating this, that your disease mapping and your TNM staging are deeply intertwined. Do not disconnect the two, and please respect these defined borders. It will make a large difference in your documentation, in your own audit, and then in your cancer registry. So with that, now there are various mapping techniques. I'm not going to go into the elaborate discussions of these, but OPD based imaging and IP. Diva already spoke imaging, but I'm broadly touching it as OPD based. You want to look at the site, subsite, Hopkins. Very good enough. simple documented, that itself is your first step towards a good clinical diagnosis. The earlier TNM UICC used to have the C factor, the certainty factor, now they have removed it. But I think this is the first clinical certainty factor that you get, the Hopkins. If you want to study more of the mucosal wave vibration, you have a strobe, and now you have biological scoping with assessing the epithelium, the basement membrane, or the lamina propria. These three aspects could be well deciphered within an OPD setting today, beyond which, like Diva explained in her slides, I think it's the para and thyroid cartilage, and in subglottic the cricoid cartilage. But it's sum total of these three that the imaging wants to study. There are various criteria she has already elaborated. But the challenge still remains for early mucosal lesions where these have very limited role. And then the gold standard, which is inpatient based, the DL scopy or an ML scopy with the biopsy. And I think that sums our mapping of the techniques. I'm just going to touch upon the biological imaging just to say that today, just simply by using colors, we are able to identify and actually give biology some amount of correlates. And that's happening more and more with research on optical coherence or Raman spectroscopy. You have a lot of work going on in this area. And we have the niche classification for the vocal cords that tells about how to improve the certainty of a diagnosis on basement epithelium, the lamina propria and the epithelium. And these patterns are actually patterns of chaotic angiogenesis. So I'm going to skip these slides for the paucity of time. I think this video is not, can I play this video here? Okay. So I think people are aware about the NBI. This video is not playing here. Can you see if you can try and play it there? But narrowband imaging is one interesting tool that has been added, again not as a mandatory but as a desirable tool that gives you additional information pre and post to help map the biological scopy of it. If it's not playing, it's okay. And today we use it very often for pre and post assessment also, in order to give us some amount of better prognostic and follow-up surveillance. And coming to the last part of assessment, which again is very integral to the first two which I spoke, the staging and the mapping. Now, I'm going back to the Hoffman's data, old paper, but very significant one, which talked about that laryngeal cancer survival was dipping among all the survivals. And we saw the era changing from surgery to non-surgical organ preservation. Now, in this entire trends, laryngeal cancer, although is a small part of head and neck, it still becomes relevant to understand that how do we choose these patients. And like they pointed out that chemoradiation was increasing on one side, but also additionally it brought out the discussion of functionality of the larynx, and the key principles of organ preservation, which is an organ that is preserved, should be an organ functional. And I think this is the onus of the radiation, medical and the surgical oncology team together to keep monitoring on this aspect of functionality through a good staging, mapping and assessment. Just these three could give us a lot of clue into this. Intraoperative assessments of tumors, if you see them, have a very significant important role to play also before going in for your complete treatment planning. And last but not the least, I'll close this with functional assessment and showing the importance of it. Now, if you look at in my OPD at our department, we have close to about 20 odd parameters that the speech and swallow therapy team uses. Akshat is here, he was there with us earlier. So now the ones in circle are some of the things that we are right now validating and we are developing. But about 20 characters that the functionality team works on to try and pick up functionality pre and post. So the most basic of speech and swallow functional effectiveness with scores of up to 40, performance scale status, the tracheostomy dependent scale, the head and neck oral intake scale, 100 ml water swallow test, a simple one, a mealtime assessment. Now I felt what we've created there is a studio kitchen. We've created a complete speech and swallow team which does that job more than what we do. I think they add much more value to the patient's care than we do. When I spend 5 minutes on that patient talking to him about the thing, they spend 45 minutes, 1 hour, they sit and feed the patient, and I think that's the one that actually gives the quality of life indicators to the patients. So they've actually looked at all of these areas, that is the oncological status, breathing, airway, safety and voice, and brought out a scoring system with some weightage, and I'm just going to give you some examples of what they do. Like this is one patient I had sent them some time back, and they did this assessment, and based on this they created a scoring and a weightage which was 2.75, and using that they gave the percentage of laryngeal dysfunction as 78% severe. I think it is a simple objective measure they gave me of a preoperative assessment of laryngeal dysfunction, which helped me make a decision of whether I should go for CTRT, whether I should go for surgery, inform the patient, and based on this decision, I was able to counsel the patient and then left him to a more informed decision, but with my suggestion. This is another patient of ours recently. I am just talking to you about a little detailed assessment which is given as a printout to a patient, and how much of meaning it can do to a patient objectively than simply telling it, because when he goes with this particular report to a particular second opinion, third opinion, nowadays fourth opinions, online consultations, it is better that they have this, so that whether it is a radiation, medical or a surgical oncologist objectively assesses the particular severity. Like in this case, he had said that the percentage of dysfunction is only 30%, and with aggressive good speech and swallow therapy, even organ preservation, non-surgical methods would work very well, and we had a good tumor board discussion, and the patient chose CTRT. But I think the point was, at the end of this particular thing, how many of them will regain this function, and that's something we are closely evaluating right now. But I have very good objective criteria beyond just saying the larynx is fixed or mobile. So a few other terms that we today should know as surgeons is that people use baseline voice analysis, perturbation analysis. Baseline analysis referring to a simple voice which is under normal circumstances, and perturbation is measuring the quantifying the irregularities or variations of the voice. Similarly, we are using waveform and spectral analysis. Waveform is basically to interpret the graph and the voice signal, and spectral is for analyzing the frequency of the voice signal. Now I'm putting all of this in one patient's graph and giving it to him. A simple assessment, not very complicated, not very costly, no major investments, but just needs the commitment of a department to say that we need to give this to a patient when he comes for early laryngeal cancer analysis, and then to make the choices of treatment. So we do this as a standard where we look at the patient's pitch, like for example, in this case over here, you see the blue line that shows that there is some form of uniformity and pitch. So various such parameters can tell about what is the status of the patient, and we get an inferencing improved voice segments of near normal tonicity and severe hoarse voice in certain places. But the objectivity is now come in, and similarly pre-laser, post-laser, how is the voice improving, what is the level of shimmer, jitter, what is the level of the overall parameters is what we can assess. We also use cervical auscultation, a very simple technique in swallow assessment for hypopharyngeal lesions. Very, very useful tool, and I think it can give a lot of information to us about early onset of strictures, what is the swallow status of the patient, when will the patient need dilatation, and based on that, penetration aspiration status. So combined with fees, it can make a large difference. I think these two are, KK has done a lot of work on this. I am very inspired by the book he's written, and a lot of information and additional knowledge can be gathered from that if you all want to know more. I'm just going to play, this is my last slide, so I'll take the liberty to play this if it works. Okay, it's not working here. This happens between the Mac and the Microsoft incompatibility, I think. So that's okay. I mean, this is just showing you a standard fees of a patient who underwent CTRT, and the entire team spending more than half an hour analyzing it, trying to create these reports, trying to look at swallow, penetration, aspiration, and then working integratedly with the diet team to see which consistency of the food we should start with first. And we also initiated along with this the taste clinics. So the taste clinics is again a very simple thing that we initiated, where we got in pure substances, weighed them, and one of the simplest thing that a person post CTRT or post this desires, that's okay. Okay. So, yeah. Since my time, how many seconds do I have now? 2 seconds. Huh? 2 minutes. Okay. 2 seconds was scary. So this is, I think, the fees procedure of the clinical team and the speech and swallow team working together, using various food consistencies sometimes, using colors. Can you all forward it a little bit? Yeah, just so when they assess the area and they look at it, they are able to look at the aspect of pooling, penetration, and based on this, they do color tests, they give us good recommendations, and I think this helps us a lot in our explaining to the patient, giving them a guarded step on what to do, which is not done by me, but by speech and swallow team and the diet team sitting together. So we have a rehab MDC that we do every week, every Thursday. For the last 6 years we are doing it, between 2 to 3 o'clock, where they all sit together and they work on all these areas. And I think it's a domain that needs to be done now. The National Cancer Grid has also helped many other centers join this effort. Sorry, yeah, I can go to the next slide. Sorry. Can you? Okay, so just before the thank you, this was the taste clinics we created. So a simple test again, which I thought, which many of us tend to forget, that during the course of CTRT, RT, one of the papers we had written, which is published now, is that even in oral cancers, if you look at it, because the lingual nerve is radiated, they have dysgeusias, they have altered taste. So taste is a very important aspect of a quality of life for a person. I'm sitting in the food city of Gujarat, I'm saying everybody of them will require taste and food. So we developed this entire thing for specifically helping them with taste rehabilitation. And we were able to show that a person who wanted to eat biryani at 3 months, we were able to help make faster work if he focused on it and bring it to him in 1 month, rather than in 3 months, rather than letting it go. A much neglected topic is what I would say. Because taste is not something we assume to say that we have to rehabilitate, but I think small efforts from the teams of speech and swallow can make a big monumental quality of life difference for the taste of a patient. Thank you very much.